examine the microvascular complications of the diabetes. So we all know that there are the three microvascular complications in the form of retinopathy, nephropathy, and neuropathy. So as a basic doctors, retinopathy, we may not spend much time on the retinopathy for the simple reason that we don't carry the fundoscope to examine all the retinas. And what we all should know that all the diabetics, especially the chronic diabetics, at least once in a year, they should screen for the retina, not for your refractive error. So you should be very clear that you ask the ophthalmologist to see the retina on dilated pupil. So otherwise, most of these cases, they miss the retinopathy, and retinopathy is of two types: non-proliferative and proliferative diabetic retinopathy. And non-proliferative diabetic retinopathy is very easy, but proliferative is very dangerous because of the sudden vision loss. So, and the other two microvascular complications are neuropathy and nephropathy. And nephropathy is a very, very, very important because of the simple reason that lot of the mortality and the morbidity with the CKD. Whereas neuropathy is also equally important for the simple reason that the most common microvascular complication or macrovascular complication is the neuropathy. But it is more troublesome. It causes a lot of morbidity. But if you see the mortality wise, I think the CKD is much more important as per the mortality point of view when compared to the neuropathy. So let us spend some time on the CKD first and then on the neuropathy. And if time permits, we will talk very little on retinopathy also. See, in the next few minutes, I would like to talk on introduction, type 2 diabetes and its association with CKD, pathophysiology, some challenges and limitations, how you manage the CKD, and finally, what are all the novel therapies and the approaches. See, you are familiar with the epidemiology of the diabetes. Is a very, very important disease, not a simple disease, very big disease, and the numbers are also very, very high. Next to the China, we are the number one. Within the few months, I think India will be the number one in the incidence of type 2 diabetes. So right now there are about 10.5 crores of the diabetics in India, and there are a lot of the people are getting the type 2 diabetes for the simple reason that physical inactivity, a strong family history, obesity, and the Indian origin itself is a big risk factors for both genetical as well as the environmental risk factors to get the type 2 diabetes. See, the expected prevalence of the type 2 diabetes was 8 to 9% in the Indian patients. So that 8 to 9% of the prevalence is a very, very high when compared to any country in the world. See, this is about the people living with the diabetes in India. Already I told you, there are barely 30 million away from the numbers expected in the 2045. And what is more important here is the control of the diabetes. And you all know that the normal control or good control of the diabetes is to keep your HbA1c at 6.5 or around 6.5, maybe not more than the 7. But unfortunately, more than the 75% of the people in India, they are living with HbA1c beyond the 7. You will be surprised that if I say that the average HbA1c of our Indian patients is 9.4. So the 9.4 HbA1c, the average, that means India is having a lot of the cardiovascular diseases, lot of the CKDs, lot of the neuropathies, etc., etc., just because we are keeping the HbA1c away from the 6.5 at the level of 9.4. So the 9.4 average HbA1c in India means that India is having type 2 diabetes and also with lot of the complications, both micro, macro, and also other complications like your tuberculosis or infections, etc. See, move to the epidemiology of the CKD as a global, more than 10% of the general population worldwide. And it is accounting for about the more than 800 million individuals. Diabetes and hypertension account for over 2/3 of the cases of the CKD. See, that is the global. So all over the world, the two important reasons to cause the CKD are diabetes and hypertension. Unfortunately, both are very close friends, and because of the same environmental factors. So the diabetes and hypertension is the common etiological factors or common environmental factors, and it's very commonly associated. So that is the reason in India, as the type 2 diabetics, 60 to 70% of the type 2 diabetics are having the hypertension, and about the 40% of the hypertensives are having the diabetes. And I'm saying that about the 10.5 crores of the diabetics, and nearly 30 to 35 crores of the Indians are having the hypertension. So you can imagine the numbers of the CKD in this population. So to control the CKD in India, you need to control both diabetes and hypertension very, very effectively. So you have to keep the fasting blood sugar around say 100 or 110 and post-mortem blood sugar around 140 or 160, and then the HbA1c around 6.5, not more than the 7, to keep all these people away from the complications, especially from the mortality point of view of the CKD or the HD. In India, diabetes and hypertension accounts for 40 to 60% of the CKD case. I think that not the 40 to 60%, maybe 70 to 80% of the case of the CKD. See, in India. So anywhere in all over the any places in the India, if the person is supposed to plan for the renal transplantation, I think only two reasons: whether uncontrolled diabetes or uncontrolled hypertension. Unfortunately, both. And very few people will be having the chronic glomerulonephritis (CKD). Unfortunately, we are not seeing the CKD much higher in our routine population because the minimal change glomerulonephritis is reducing in incidence, and also other glomerulonephritis are also increasing in incidence. But what glomerulonephritis which is increasing recently is the lupus nephritis or autoimmune disease related glomerulonephritis. See, the estimated more than 40% of type 2 diabetes have the CKD. Indian CKD study showed 37% of diabetic patients had the CKD. That means CKD means not the end-stage renal disease. Anywhere your GFR is falling down less than the 90, that means the people are having the CKD. Maybe the stage 1, stage 2, stage 3, stage 4 and the stage 5. When it is the stage 5, we consider as the end-stage renal disease, then there is only option is the renal replacement, either in the form of the dialysis or in the form of transplantation. But unfortunately, in India, at the time of the diagnosis itself, 40 to 60% of these people are having the chronic complications. So when you are diagnosing one case, say Rama Rao, aged about 35 years, you diagnose diabetes today with the fasting blood sugar 150 and the post-mortem blood sugar 250. So I mean that patient is having diabetes right now. So you are diagnosing diabetes de novo today. Suppose if you check the microalbuminuria, that is positive. If you take an ECG, LVH is positive. If you check the blood pressure is 150 by 60 or 150 by 90. If you check the dyslipidemia or lipid profile, the LDL will be 130, HDL will be 40 or 30 or 25. So it means that this fellow, even though the diagnosed diabetes today, but already he has been living with the diabetes uncontrolled or undiagnosed, and then undiagnosed diabetes, hypertension, undiagnosed lipid profile or dyslipidemia, etc. and etc. And also the nephropathy because he already had proteinuria. And also LVH already had left ventricular hypertrophy, and it is independent risk factor for the heart failure and also the ischemic heart disease. So on the day of the diagnosis itself, and some of the type 2 diabetics, they may present with the complications. So as a specialist or as an interested to do the diabetes practice, so don't be happy with the diagnosis of the diabetes alone on the day 1. On the day 1 itself, you have to pick up some of the complications. So is the patient is having CKD? Or the diabetic nephropathy, or is the patient is having asymptomatic ischemic heart disease, etc. etc. So you need to examine the fundus, you need to examine the peripheral nervous examination or neuropathy examination. You have to examine you have to rule out the nephropathy, you have to rule out the vasculopathy, etc. So the significance of addressing the CKD in the type 2 diabetes. Already I told you. Why? What is the significance? Because of the more morbidity and the more mortality. India, we are getting the type 2 diabetes at an younger age group, say maybe at the 25 years or 30 years or the early 40s. So these people have to live with the diabetes for another 30 years or 40 years or 80 years. If you consider that the average lifespan of the Indians is 70 plus or 80 plus. See, imagine the years of the life with the diabetes or with the hypertension. So obviously these people will be having more and more complications. See, high prevalence. CKD is highly prevalent among the type 2 diabetes. Studies have shown that up to 40% of the individuals with the type 2 diabetes have the CKD or develop the CKD. So increased morbidity and the mortality. CKD is also with an increased risk of cardiovascular disease, ESRD, premature death. See, I told you earlier also, most of the CKD population, they die in the hands of the cardiologist rather than the nephrologist, because even though when the creatinine is 2.5 or the 3 or the 4, they don't require a dialysis. They don't require the transplantation. So what they require is, so not to progress the further increase in the creatinine levels. But unfortunately, they will develop the ischemic heart disease because CKD is a big risk factor for the ischemic heart disease. Hypertension is a risk factor for the ischemic heart disease. Your hypoalbuminemia is a risk factor for your ischemic heart disease. Anemia is a risk factor for cardiac problem. LVH is a risk factor for the cardiac problem. So these fellows, if the patient is also a smoker and the obesity or the sedentary lifestyle, and with a strong family history of the IHD or the CKD in the family, and obviously all these people, they die prematurely with your ischemic heart disease or sudden cardiac deaths or the heart failures. Progression of the kidney disease, type 2 diabetes is a major risk factor for the progression of the kidney disease. Managing the type 2 diabetes effectively can help slow down the progression of the CKD and delay the need for the renal replacement. That is the most important. So the most important take-home point from today's lecture is please slow down the progression of the CKD. We can't stop the progression of the CKD. At least you can slow down the progression. So from today, he is having the creatinine of 2.5 or the 3 by the time you diagnose this. Plus see that next 5 years or 6 years, this creatinine of 2.5 will not move to 7 or the 8. So to require the transplantation or the dialysis. So next year it may be 2.8, and the next year it may be the 2.9, and then after the 5 years it may be the 3.5, and after the 10 years it may be the 5, and only after 15 years or 20 years of the diabetic life or the CKD life, so they need the transplantation or the dialysis. So that is the beauty of our diagnosis at an early time, and also managing the CKD in a holistic approach. So managing the CKD means not in the point of the kidney alone. So CKD means you need to understand the anemia, you need to understand the hypocalcemia, you need to understand the renal dysplasia or osteodystrophy, so etc. See, because these people are more prone for lot of the infections. The CKD people are more prone for the lot of the infection like pulmonary tuberculosis, pneumonia, sepsis, etc. The significance of addressing the CKD in the type 2 diabetes. So addressing the CKD in the type 2 diabetes is of utmost importance due to the several reasons. What are all the reasons I told you so far? So you need to give a cardiovascular protection. So addressing the CKD in the type 2 diabetes is crucial for the cardiovascular protection. CKD is an independent risk factor for the cardiovascular disease. Type 2 diabetic patients with CKD are at even higher risk. Managing the CKD, the risk of the cardiovascular events can be reduced so that you can arrest the premature death. And the most important thing is the quality of the life. See, you have to improve the quality of the life. Effective management of the CKD in type 2 diabetic patients can improve their overall quality of the life by preserving the kidney function, reducing the complications, preventing the need for the dialysis or the kidney transplantation. So what will happen when the creatinine level is 3.5 or 4 and 5? So obviously these people will have the nausea. These people will have the vomitings. These people will have asthenia. These people will have the anemia, maybe because of your nutritional deficiency or maybe because of your erythropoietin deficiency. So in the presence of the anemia, in the presence of the malnutrition, in the presence of the nausea, vomiting, and also other uremic symptoms, so obviously the quality of the life will be very much disturbed. On the other hand, on your dietary restrictions in the CKD, so you have to restrict the salt, you have to restrict the sweets, you have to restrict the oil, you have to restrict the other things. So even the coconut water or the prickles or high protein diet. So high protein diet is not a contraindication for Indian patients because our people are the protein deficient. So even though your book says that 1 gram per kg body weight is the normal protein requirement for the normal population, whereas in the presence of the nephropathy or the renal failure, we have to reduce to 0.8 grams per kg body weight. That was our teaching in the undergraduates or in the postgraduates. But Indian patients, even though they are having the CKD, you need not restrict to the 0.8 grams per kg body weight. You can as well give to the 1 gram per kg body. But the only restriction is the animal protein. So that contains a lot of the ammonia, and these people will have more and more uremic complications. So the protein supplementation in the form of the vegetable sources is very much needed for the CKD population. So the risk factors for the diabetic kidney disease, the older age. So obviously, so the more the elderly, definitely they will be having more chances of having the CKD. And male people are more prone to have the CKD. And the race, so Asians are at high risk of getting the CKD along with your American Indians, your blacks, that is our African population, and also the Pacific Islanders. And hereditary, again, it runs in the families, CKD. So the family history of the DKD means diabetic kidney disease. So earlier CKD in the diabetes is called, now is considered as a DKD. DKD means the kidney disease. It's a chronic kidney disease caused by the diabetes. So DKD means diabetic kidney disease, a new nomenclature. So earlier we used to call it as a CRF. Now it is a CKD. No more chronic renal failure. Now the chronic kidney disease. Earlier we used to call it as ARF for acute renal failure. Now it is AKI, acute kidney injury. So in the same way, the DKD means diabetic kidney disease. And genetic kidney diseases, they are the runs in the families. Systemic conditions, hyperglycemia, that is your diabetes, obesity, hypertension. So unfortunately, most of the people, Indians are right now, are having all these three, and also dyslipidemia. So that is metabolic syndrome. Kidney injuries, acute kidney injury, maybe because of your NSAID induced or snake bites or poisonings or gastroenteritis or dehydration, etc. And the toxins, so maybe the organophosphorus poisoning or aluminum phosphate poisoning, etc. Smoking also very, very dangerous. Smoking in diabetes always leads to a lot of the complications, so premature death. So when compared to smoking and alcohol, I think smoking is very, very dangerous in the diabetic individuals. So they should stop smoking in any form, whether it is a BD or cigarette or cigar or kaini or gutka, etc. So smoking is 100% forbidden for the diabetic individuals. So the dietary factors, high protein intake is not there in our Indian population, maybe in the Western population. So now, except the last one, all the other are the very big risk factors for Indian patients. See, so our people are getting older because now the lot of the people are seeing 70th birthday or 75th birthday or 80th birthday, and the 50% of Indians are the males, and then the Asians are itself, it's a big risk factor. We have the strong family history of the IHD and the CKD, and also hyperglycemia, obesity, hypertension, and dyslipidemia are very common in our Indian population because the metabolic syndrome, the capital of the metabolic syndrome in the world is India. On one hand, we are more obese population. On the other hand, we also have the malnutrition population. And kidney injuries, AKA, and toxins and smoking are very common in our rural India, taking the toxins. And then the dietary factors, okay, you can exclude that factor. So these are very, very important. So whenever you see a diabetic with this background, so please think that this diabetic is at high risk of getting the CKD. So that is the most important point of this slide. So the most important thing is, whenever you see such a diabetic individual with a strong family history, with a metabolic syndrome, etc. So definitely you have to stop. You have to advise stop smoking. You have to advise not to increase the body weight, or if the person is overweight or obese, so reduction of the body weight is also very much needed. And we can't change the genes or the parents, so the families, we can't do anything. But other things, we can control the blood sugars, we control the blood pressure, we can control the body weight or the obesity, and also the lipids, etc. So what is the pathophysiology of your CKD? See, the mechanism of the hyperglycemia, inflammation, fibrosis, and oxidative stress. So these are the very important. Hyperglycemia, so the more the blood sugars, so definitely it causes oxidative stress, it causes the endothelial damage, it is a vascular inflammation, and there will be the fibrosis in your glomerulus or in the tubules. So all these will lead to the diabetic kidney disease. So it is characterized by structural and the functional abnormalities in the kidney, leading to the progressive loss of the renal function. It typically manifests as the microalbuminuria, followed by the macro, then the declining the GFR, and then finally ESRD. So the first step is the microalbuminuria. That is the reason most earliest lesion to detect in the DKD is your microalbuminuria estimation. So all the population, even on the day one, you should get the microalbuminuria or urinary albumin creatinine ratio, USCR, in all our population. So accordingly, we can say whether this fellow is at risk of getting the CKD or the not. And if you don't check the microalbuminuria, so these people will go into the macroalbuminuria. So the normal is less than the 30 milligrams per day. And if it's 30 to 300, we consider as the microalbuminuria. 300 to 500, we consider as the macroalbuminuria. More than the 500, we consider as the proteinuria. And if it is more than 3.5, we consider as the massive proteinuria. So you need not remember these numbers. But one thing is very clear. So the more the protein loss in the urine, so definitely the kidney is at risk of getting the CKD. So after some years, and slowly the creatinine will go up. So once the creatinine will go up, so definitely the GFR will come down. So finally, when the GFR is less than the 15, we consider as the ESRD. then the only two options, which are very, very serious options and very costly options, is either lifelong dialysis, hemodialysis, or peritoneal dialysis, or the transplantation. See the normal glomerulus and the diabetic glomerulus. See the differences here. See that. Okay. So the podocytes, the foot processes, the mesangial cells, the capillary loop, mesangial matrix, glomerular basement membrane, endothelial cells. So all these will be altered or disturbed or destructured in the presence of uncontrolled diabetes. See the foot processes. So this is the first one is the normal and the second one is the abnormal. See the foot processes. So they lost its rhythm. And see the podocytes. So podocytes changes. And then see the mesangial cells. So the mesangial cells are increased. And then the capillary loop. See the capillary loop. It is dilated. You see the mesangial matrix. It's very much enlarged. And glomerular basement membrane very much thickened. And endothelial cells, that is also thickened. So this is the basic pathology. That is the reason when you are in a doubt. See, not all the kidney disease in the diabetes is because of the diabetic kidney disease. Sometimes, non-diabetic kidney disease in a diabetic individual. So when you are in a doubt, we get the kidney biopsy. See, normal kidney morphology and the structural changes. Diabetic kidney disease induces the structural changes, including the thickening of the glomerular basement membrane, a fusion of the foot processes, and loss of the podocytes, with the denuding of the glomerular basement membrane and the mesangial matrix expansion. So all these structures are there, then the diagnosis is diabetic kidney disease. Otherwise, it is not the diabetic kidney disease. Something else is the reason for your kidney problem in that particular person. So the diagnosis of the kidney disease in a diabetes is not always due to the diabetes. Sometimes maybe non-diabetic also. So suppose if you miss that non-diabetic cause, so you may not recognize that non-diabetic cause and the people will die because of the non-diabetic cause of a diabetic kidney disease in diabetic individuals. Okay, now the mechanism. See the mechanisms leading to the kidney damage in the diabetes. Podocyte injury. Podocytes play a crucial role in maintaining the glomerular filtration barrier. So hyperglycemia and inflammation, your vascular inflammation or glomerular inflammation contribute to the podocyte injury, disrupting the filtration function. So once the podocytes are disturbed, so your filtration function will be disturbed. So once the filtration function is disturbed, so what will happen to your, so there won't be much good filtration. So obviously, lot of the excretes may not be excreted through the kidneys, then they enter into the bloodstream, they cause the uremic symptoms. So the renal inflammation, the persistent hyperglycemia triggers the inflammatory responses within the renal tissue. Infiltration of the immune cells and the release of the pro-inflammatory cytokines contribute to the kidney damage. So by this time, you all know that the pro-inflammatory cytokines like interleukin-1, interleukin-6, interleukin-12 or tumor necrosis factor. So the different pro-inflammatory markers will be there or cytokines will be there. So there will be increase in its number, increase in the number in a big way. So finally they damage the glomerulus and they cause the renal inflammation. And what about the fibrosis? A chronic inflammation because of these uncontrolled diabetes, etc., and the oxidative stress promote the renal fibrosis, causing the structural alterations in the kidney and impairing the functions. So once there is a structural changes, so obviously the functional changes will start. So once the functional changes starts, so your creatinine level will go up and your GFR will come down. And glomerular hypertension. So this is a very, very important to use the drugs to control the glomerular hypertension in the CKD. So some drugs will act here, some drugs they won't act it. So that is the reason in the CKD population. So some of the important antihypertensive drugs are the compelling indications to use in CKD. So here the glomerular hypertension, hyperglycemia induces the glomerular hypertension, leading to the increased intraglomerular pressure and subsequent damage to the filtration barrier. So all these four are very, very important pathophysiological mechanisms to cause your CKD. So you have the glomerular hypertension, you have the fibrosis, you have the renal inflammation, and you have the podocyte injury, all because of the single factor, uncontrolled diabetes. Uncontrolled diabetes. So if you control the diabetes very effectively, so these changes will not occur. Once these changes will not occur, these people will not have the CKD. So don't keep our diabetic individuals live along with the uncontrolled hyperglycemia. See the pathophysiology of the diabetic kidney disease mechanisms: hyperglycemia, inflammation, fibrosis, and oxidative stress. See the pathophysiological factors, the hemodynamic there, increase the RAS activity. So more the increased RAS activity, more the your angiotensin 2, that is a potent vasoconstrictor. So increased endothelins, metabolic advanced glycation end products, or RAS activities, or tumor TGFs, and then the VEGFA, your collagens. So these are all the pathophysiological factors. They will be disturbed and increased in the presence of uncontrolled diabetes. So they lead to the glomerular hypertrophy. They will lead to the mesangial expansion, tubulointerstitial fibrosis and the inflammation, glomerulosclerosis, and the kidney fibrosis. Okay. So the chronic low-grade inflammation is a hallmark of the CKD or the DKD. Hyperglycemia triggers the inflammatory signaling pathways. So what are they? The activation of the NF-kB, that is the nuclear factor Kb, is a key mediator of the inflammation, promoting the expression of the pro-inflammatory genes. And then the immune cell infiltration. So there the macrophages, T cells, they infiltrate the renal tissue, amplifying the inflammatory response. So if you don't control the blood sugars very effectively, so all these changes will occur, and finally they lead to the CKD. Now, what are the challenges and the limitations in the diagnosing the CKD in type 2 diabetes? See, asymptomatic nature, that is the most important in the CKD. See, unfortunately, most of the people are asymptomatic. And in India, no person will enter to a doctor's chamber without any symptoms. So by the time the patient is asymptomatic in CKD, they are already in the stage 4 or the 5. Even the stage 3 of your CKD is asymptomatic. Stage 3 means 30 to 60. Stage 4 means 15 to 30. Or stage 5 is less than the 15. There are some people I've seen that even at the creatinine level of 8 or the 9, they are asymptomatic. So when take the blood sugar creatinine, another day, maybe 2 months back, I have seen one patient with creatinine 12.5. So my wife did 3 times creatinine. The patient is asymptomatic. All the 3 times, one time it is 12, another time it is 12.6, another time it is 12.8. So average is 12.5. So without any symptoms. So you have to subject for the immediate dialysis in that particular person. Otherwise, these people will die of the acute myocardial infarction or any arrhythmias, and then the sudden cardiac deaths also. So that is the asymptomatic nature. The CKD in its early stages is often asymptomatic, leading to the delays in the diagnosis, as patients may not seek the medical attention until the significant renal damage has occurred. So by the time they are the symptomatic, they are already in the stage 4 or the 5. Very little can be done. So there we can't stop the progression of the disease. We can stop the progression of the disease provided if you diagnose the CKD in the stage 1, stage 2 or stage 3. When the patient enters in the stage 4 and 5, it is only a matter of the few months or the years to reach a stage of the end-stage renal disease where the only 2 options is the transplantation or the dialysis. So that is the one thing. So that is the reason we have to diagnose the DKD in the early phases only, in the asymptomatic phase only. So don't please check the creatinine levels also at least once in 6 months or once in a year in all your diabetic individuals, even though they are asymptomatic. Influence of the glycemic control. See, the fluctuations in the blood glucose levels can impact the kidney function, making it challenging to discern the effects of the diabetes from those of the CKD. It is always bad if you allow the diabetic individual to live with the very high fluctuating blood sugars. Even today, most of my patients, maybe 65 to 75% of my patients, their HbA1c is beyond 8, even though they are the 9. So I am not doing good as far as keeping the HbA1c at 6.5 or the 7. But keeping the HbA1c at 6.5 or 7 is very much needed with the good support of the patient also. Not only the support of the patient, the family members also. So these are very, it's a big risk factor to keep the HbA1c beyond the 7 or 8 to reach a stage of the CKD population. So fluctuations is very, very important, and fluctuations should not occur in most of the diabetic individuals. So most of the time, smooth trialing of the blood sugars, maybe somewhere between 90 fasting to 180 or 190 of the postprandial. Otherwise, most of our people know the fasting will be 250, post one will be 400, and then after the prolonged fasting for the 1 day or 2 days or 3 days, the fasting will be 60, and then the postprandial will be 120, and then another 2 days, again the blood sugars will be 200 or 400. So these fluctuations, so what will happen when the fellow is in the severe hyperglycemia? So they cause oxidative stress, they cause vascular inflammation, or they cause advanced glycation and product headaches. When they are the low blood sugars, they release the counter-regulatory hormones. So the counter-regulatory hormones are the cortisol or etc. etc. Cortisol, growth hormone, epinephrine, norepinephrine. Again, they cause endothelial damage. So both hyperglycemia and hypoglycemia, both are injurious to the vessels. So that is very important. And then variability in the estimated GFR. The commonly used GFR equations may have the limitations in the accuracy, especially in the diverse population. So you have a lot of the equations to get your GFR done. Okay, ethnicity, age, muscle mass can affect the reliability of the GFR values. Say some fellows know creatinine level is 1.5. Another fellow, the creatinine is 2. So in the broader sense of view, we think that the creatinine 2 is much more when compared to the creatinine 1.5. Suppose if you check the GFR, this 1.5 fellow, 1.5, the GFR may be 40. Whereas the creatinine 2, the GFR may be 80. So give importance to the GFR rather than the creatinine. So all the complications are because of the GFR reduction, not your creatinine elevation. So it's directly proportional, creatinine elevation and the GFR. But sometimes, depending on the age or ethnicity or the measurement or because of the muscle mass, so that may vary. So in your all smartphones, you can have this, you can have that GFR calculator. So if you enter the three things, one is the age of the patient, and then the gender of the patient, and the creatinine, immediately you can get the GFR. Okay, so give more importance to the GFR rather than the creatinine. Urinary albuminuria measurement. So this is the most important. Albuminuria is a key marker for the early renal damage. Variations in the urine collection methods and other factors can affect the accuracy of the albuminuria measurements. So some people, they call this midstream urine, okay, or early morning urine, etc. So anyhow, so the most important thing is urine estimation for your protein. Maybe the albuminuria or your microalbuminuria or urinary albumin creatinine ratio. So these are the very important. So the paradigm of the natural history of the CKD continues to evolve. In many patients, DKD does not follow the classic pattern of the glomerular hyperfiltration progression to the persistent albuminuria associated with the hypertension and declining the GFR. So anything happens, see, the guidelines are there to guide us, but the treatment must be renewed in the same way. So some patients know, so they progress very rapidly. I have seen few patients with the creatinine 2.2 in 2022. Now the creatinine level is 12.5 or 13, posting for the dialysis within the 2 years. On the other hand, creatinine 3 in 2000, now the creatinine level is 5.5. So 24 years, from 3 to the reach to the 4.5 or the 5. On the other hand, within the 2 years, the creatinine level has doubled also. So it all depends on the many factors, but that is very clear. So the diagnosis: hyperglycemia, cellular injury, microalbuminuria, GFR, hypertension, cardiovascular disease, kidney complications. See, this is a very, very important slide. You see that hyperglycemia, cellular injury, other pathology. So these are very important. So it is much earlier than the GFR decline, microalbuminuria. See the microalbuminuria. GFR reduction starts later. So these are the factors related to the therapeutic inertia. So why the therapeutic inertia in DKD population? So first, concentrate on the patient. So denial of the disease. He doesn't know that he is living with a CKD. Lack of awareness of the disease progression. If you say the albuminuria or you check the creatinine levels, so he goes to the lab. No, get to the only fasting and PP. I am a diabetic. I am very perfectly all right. So don't do any other tests except fasting blood sugar and PP blood sugar. So lack of the awareness of the disease progression. Fear of the drug side effects. Reluctance to initiate the injection therapy. Suppose the creatinine, the potassium levels are high, the creatinine level is high, the postprandial blood sugar is very high. So the doctor prescribed the insulin, because that is the time where you have to use the insulin. You should not use the OHS, but still the people will take only the OHA for the fear of the injections. They stop taking the insulin. So the progression of the CKD is much higher in those individuals. Concerns about the more complication therapies, polypharmacy, treatment cost, lack of support from the family or his friends. So these are all the patient factors. They are very reasonable factors as far as the patient is concerned. But the education is very important, or awareness is very important. Okay. So in that way, if you sit with the patient, and if you spend some time with the patient, and if you tell your examples of the other patients to that particular patient sitting in front of you, so definitely these people will realize the importance of your investigations, and then you can pick up these cases much early. So this is the very important. So the only way of relieving these patients factors is your good continuation or communication with your patient. Okay. Then coming to the physician, our part. So time constraints, we are so busy, we can't spend more than 1 minute or 2 minutes or 3 minutes with the patient. So that is very important, not with the patients, because the time constraint, because you are very busy with your WhatsApp messages or with your YouTube viewing. So this is very important, time constraint. Okay, lack of the supporting staff, concerns about the treatment costs, underestimation of your patient's needs, lack of information or understanding of the new treatment options. I think that is the most important among our physicians part. I mean, physician means all our people, our clinicians, are the true doctors. So lack of understanding of the new treatment options. Say no clear guidelines on individualizing the treatments, and concerns over the patient adherence, and the poor communication with the patients. So these two are very important. So we have to update our knowledge. See, the science, the medical medicine is an ever changing subject. So one thing is which is constant in our medical science is the change. So changes every day. So that is the most constant. Change is the most constant in our medical profession. So we have to change ourselves for the betterment of our understanding of this pathophysiology, and also important. So these are the physician's parts. So and then the healthcare system. So the patient is good, you are good, but between us there is a healthcare system. That is that lack of the clinical guidelines or contrasting recommendations. So no clear guidelines. Difficulties in the visit planning. So these are all, especially the government doctors, they are busy with your office work. So sending miles to your DMHO or your other population rather than spending the time with the patients. So that is the more important. Difficulties in the visit planning, and no decision support. So you have to take the permission from your HODs or from your superintendents or from your DMHO, etc. No team approach to care. You tell one thing today, tomorrow another doctor sees that patient, and he changes the total total management. So that is the more important. The poor communication between the physician and the staff. So we all think that the patient is the poorest guy, but I think that the most important person is the patient. So because of the patients only we are here. Okay. So unfortunately, most of the people, they think that they are very superior. They don't care the patients at all. That is the most that thing we should consider. That limitations in the prescribing and the reimbursing the innovative drugs. So sometimes our hands are very tight. So in introducing the motor, so for example, if you see the diuretic here, Finerenone, a beautiful diuretic, has entered into the market. So that is our mineralocorticosteroid receptor agonist, that is the steroid sparing. Very good drug, but the cost is about 100 rupees a day. So 10 milligrams is available, 20 milligrams is available. When the GFR is more than the 60, you can start with the 20 milligrams. When the GFR is less than the 60 or the 30, you can change to your reduce the dose to 10 milligrams. So very beautiful drug, it acts, but unfortunately because of the cost constraints, we may not give the same prescription to all the patients. So that is also very important. So the lack of the disease registries. So that is also very big problem for our population. So these are the different factors. So some are the physicians factors, some are the patient factors, some of our healthcare systems. Now move on to the diagnosis of the DKD. So criteria for the DKD, either of the following present for the more than the 3 months. One, markers of the kidney damage. So that is your structural damage. So albuminuria. Another one is decreased GFR. So GFR is less than 60 ml. So these two are the should be present more than the 3 months duration. So one is albuminuria, the second one is GFR. See importance of the albuminuria here. Increased risk of the CVD and the CV death with albuminuria. See the GFR more than the 60. Here the diabetes duration. See 0, 10 years, 20 years, 30 years. So once the GFR coming down, the albuminuria will go up. So then they definitely, the last one, third one is the increased risk of the ESKD, that is end stage kidney disease. So this is the very important slide, shows you A1, A2 and A3. A1 is normal to mildly increased albuminuria. A2 is moderately increased albuminuria. And A3 is severely increased albuminuria. Here G is your glomerular filtration rate. So this is of the 5 grades. 3 is divided into 3A and 3B. So 3 I told you 30 to 60 GFR is the 3 and 30 to 45, 45 to 60. So 45 to 60 is the 3A and 30 to 45 is the 3B. And then the 15 to 30 is the 4 and less than the 15 is the 5. 1 is more than the 90, 2 is 60 to 90. So depending on your GFR, so you divide all these things. So depending on your albuminuria, you are dividing into A1, A2 and A3. See the red marks here. So red marks means very high risk individual. And if you see the top red mark, that is our A3. See if you see the GFR, it is about 45 to 60. So even at the 45 to 60, if the albuminuria is A3, so definitely this patient is having very high risk individual, very high risk individual. Even when the GFR is almost 35 to 40 means the creatinine may be 1.6 or maybe 2 also, or 2.3 or 2.5. So even at the creatinine level of 1.5 or the 2.5, so the patient is at very high risk of getting the CKD. So this is a very important, I think the best slide of our today's talk. So on one hand, it is the GFR. On the other hand, you are having the albuminuria. Albuminuria 3 plus or the 4 plus are very high albuminuria. Even in the presence of the normal GFR or obviously in the 3A GFR is at very high risk of getting the CKD population. So you have to give more importance to the GFR and also to the albuminuria. What is the importance of early detection? Preventing the progression. So early detection means a timely interventions, including the lifestyle modifications and also the medications to prevent or slow the progression of the renal dysfunction. So you can use the drugs to reduce the blood pressure, you can use the good drugs to reduce your hyperglycemia, or you can add the insulin also to reduce the blood sugars. Okay, so all these things so that you can prevent the progression. Cardiorenal syndrome, that is a very big syndrome in diabetes. Cardiorenal syndrome. CKD is closely linked to the cardiovascular disease, some autonomic dysfunctions, some sympathetic overactivity, okay, or maybe the RAS activity. So there may be the left ventricular hypertrophy. There will be the systolic dysfunction. So there will be the diastolic dysfunction. So there will be the glomerular hyperfiltration, or reduced hyperfiltration, or increased hypertension, glomerular hypertension, or increased fibrosis, or tubular necrosis. See, all these things will be there in your cardiorenal syndrome. Finally, these people not only having the ischemic heart disease, but also the heart failure. So we can give the good quality of the life provided if the patient is ischemic heart disease, because we can put one stent or the 2 stents or the CABG and the people will be very happy because good flow in the coronary arteries. But suppose if your diagnosis is the heart failure, then the quality of the life will be very much disturbed. So the only option is heart transplantation, which is not possible. So heart failure means there will be the dyspnea, there will be orthopnea, there will be PND, there will be pedal edema, and then they can't walk a few meters. So in the sitting on the ground is difficult. Okay, so these are all the different. Even a common activity is also the patient is used to get the breathlessness. So even at the rest also they get the breathlessness. So the quality of the life will very much disturbed in the presence of the heart failure. So heart failure is also very common in CKD population, in uncontrolled diabetic individuals. Okay, so this is the cardiorenal syndromes. And reducing the healthcare costs. So early intervention can mitigate the economic burden associated with advanced CKD, including the costs of the dialysis and the transplantation. So forget about the transplantation. But the dialysis, we are having a lot of the dialysis machines in our area. When I was in a postgraduate year, we have only 3 machines, dialysis machines with Dr. Sachinan Raj garu, that medical specialties hospital. Now, can you imagine? Can you anyone tell the exact number of the dialysis machines in Kakinada right now? 3 machines in 1990. Now, how many machines in Kakinada? Dialysis machines? More than that. More than that. More than that. Maybe 400 to 450 machines. They are doing four shows a day. Sometimes like your Kalki day 1, 5 shows also. Okay, morning, matinee, first show, second show. So 4 shifts. Each shift about 3 to 4 hours. Dialysis, 24 hours. All the machines working in sometimes. So imagine the number of the diabetics, number of the CKD population only in Kakinada. Earlier, no dialysis mission from Srikakulam to maybe from Srikakulam to Hyderabad also. So the only dialysis machines available other than Hyderabad and Chennai is the Kakinada at that time. Okay, first nephrologist of Andhra Pradesh is our Rajgar. No nephrologist was available even at Vijayawada or at Visakhapatnam also. So now you can imagine the number of the dialysis in Kakinada, number of the dialysis machines in Rajahmundry, in Amalapuram. Okay, even in Tuni, they have the 3 or 4 machines. In Ramchandrapuram, they have the 2 or 3 machines. Okay, so even a small places also we are having the dialysis machines. So imagine the number of the CKDs or DKDs are presenting in the society. So it's a very big topic and it's a very interesting topic, very useful topic and most needed topic of today's modern diabetes practice. Because a lot of the people are getting the DKD. So our aim is slow down the progression of the DKD. Our aim is recognize the DKD at an early stages. Our aim is give the good drugs which can reduce or which can arrest the progression of the DKD. So this is the very important. Otherwise, the cost will be very high. Thanks to the Arogyasri. Otherwise, they have to spend at least 5,000 to 10,000 for each dialysis. So before the dialysis, you have to get the urea, creatinine, hemoglobin, electrolytes. After the dialysis, again you have to get the creatinine and also the electrolytes. So imagine the lab cost. So you have to pay nearly 1,000 to 1,500 rupees to the lab. And then for the dialysis, each dialysis, you have to pay about 3,000 to 4,000 rupees and to and fro from the village. So all these dialysis patients, they need the attendant. So see the working hours lost with the patient and also with the attendants. So a lot of the money is involved with each dialysis. So now the Arogyasri is available. So most of the people are getting the, I think 80 to 90% are getting the dialysis under the Arogyasri only. So if you come out of the Arogyasri, then the cost also very high. That is the reason most of the people, they used to die because of the improper dialysis or incomplete dialysis. So the same thing here I told you. Now the prevention and the treatment. Okay. Although multiple strategies are now available to slow the diabetic nephropathy progression, prevention of the kidney disease remains the crucial. The risk of developing the diabetic nephropathy is particularly reduced by achievement and maintenance of the good blood glucose and the blood pressure. Again, on the day 1, I told you ABC is very important in the diabetes. What is A? A1C. That is your diabetes control. What is B, Ramu? Blood pressure. What is C, Lakshmi? Cholesterol. So that is very important. Lakshmi endukante ado Lakshmi untadani. Oh, bachelor. Okay. So prevention and the treatment of the DKD. Management of the cardio-renal risk factors, lifestyle factors like diet, exercise, stop smoking. These are very important. Glucose estimation is very important. So keep the glucose, keep the blood pressure under control. Keep the lipids also under control. Okay. Blockade of the renin-angiotensin aldosterone system and in the type 2 diabetes SGLT2 inhibition. I will tell you SGLT2 inhibition at a later time. See the picture, beautiful picture here, the kidney. See how many diseases bombarding the kidney in a diabetic individual. So now the metabolic syndrome on the top, 12 o'clock position metabolic syndrome, 1 o'clock position you have the protein intake, that is our animal protein intake, more fish, more biryanis, etc. etc. Smoking at 2 o'clock position, at 3 o'clock position, we can't change our parents' genetics. And then the oxidative stress at 4 o'clock, fibrosis 4:30, at 5 o'clock inflammation, at 6 o'clock systemic and intraglomerular blood pressure, and then the RAS activity, albuminuria, glycemic control, dyslipidemia, obesity. See, all these are bombarding day in every minute and every hour on the kidneys. So to keep our kidneys active, I think this is also one of the best slides. So you have to take care of all these things. So again, you have to take care of your metabolic syndrome, your protein intake, cessation of the smoking. So genetics, we can't do anything, but oxidative stress can be reduced by your yoga, your meditation, and you are keeping your body weight at a higher ideal level. Fibrosis, inflammation, blood pressure, cross activity. So you have to use the ACE inhibitors, ARBs here, albuminuria, glycemic control, dyslipidemia, obesity. Okay, glucose control. Kidney benefits of intensive insulin therapy demonstrated by the diabetes control and complication trial, epidemiology of the diabetes interventions and the complication trial. See, the moderately elevated albuminuria, duration of the observation is 8 years, conventional insulin therapy 15.8%, intense insulin therapy 6.8%. Okay. Then the severely increased albuminuria, again the intense insulin therapy 1.4%, conventional insulin therapy 9.4%. GFR reduction, intense insulin therapy 24 numbers and conventional insulin therapy it's about 44 numbers. So ESR end stage kidney disease progression in the intensive insulin therapy 8 numbers, whereas our conventional insulin therapy 16 numbers. So you all agree with that intense insulin therapy is much more important to keep all these things at a lower level. Otherwise, these people will enter into the end stage renal disease. So this is the lifestyle measures. So what are all the lifestyle therapy in your CKD population? Physical activity. So physical inactivity itself is a big risk factor. Nutrition is very, very important. So nutrition in the form of your carbohydrates. So more of the complex carbohydrates, more of the fiber, less of the salt, and then the good protein intake, especially the vegetable protein, and then your fats. So these are all comes under your nutrition part. And then the weight loss. If the person is overweight or the obesity. If the person is normal weight or the underweight, no weight loss. So weight loss within the brackets, overweight or obesity. And then the first line therapy, metformin. So you know that metformin is usually the first line of the management of the type 2 diabetes, but you have to respect the kidney function when you are using the metformin therapy. When the GFR is less than the 30, stop using the metformin. When the GFR is more than the 60, use the usual doses of your metformin. When it is between 30 and the 60, you have to reduce the dose of the metformin. So that is your take home point in the metformin. 30 and 60, you remember. Less than 30, don't start, or if the person is getting, stop it. More than the 60, you can start. If the person is taking, continue. Between the 30 and the 60 of the GFR, if the person is taking the metformin, try to reduce the dose. Try to reduce that. Suppose he's getting 500 mg a day, you can continue. Suppose he's getting the 1000 milligrams a day with between 30 and the 60, you can continue. Suppose the person is getting the 2 grams a day, you have to reduce to 1000. If the person is getting 1500, again you have to reduce to the maybe 1000 or 850 or 500. So accordingly you can divide it. So that is the reduced dose, discontinue. And the SGLT2 inhibitors, very, very useful drugs in the management of the CKD because it's a cardioprotective drug. It is a renoprotective and also cardioprotective. So the best cardioprotective and renoprotective drugs among all the OHS is the SGLT2 inhibitors. So again here, when the GFR is less than the 30, don't initiate, or if the person is getting it, you can stop it. In kidney failure, that is our end stage renal disease, you have to stop it. So to use the SGLT2 inhibitors, so the minimum GFR is above 30. For all of you, I think above 45 or the 60. So then only you have to use the SGLT2 inhibitors. Suppose if the creatinine level is 4 or the 5, don't use SGLT2 inhibitors because the GFR is already maybe 20 or 25 or 30. So additional drug therapy is needed for the glycemic control. GLP-1 receptor agonists, they are the good drugs, but they are the parenteral, once in a week, etc. Now the oral GLP-1 receptor agonist, oral semaglutide is also available. You can use it provided the person is obese. DP4 inhibitors, all the DP4 inhibitors can be used in the CKD, provided and linagliptin, the teneligliptin, you need not change the doses, whereas the other gliptins you have to reduce the dose. And nowadays we are not using the teneligliptin because it's not cardioprotective, because it increases the QTC prolongation, it causes QTC prolongation. So the only DP4 inhibitor where no dosage adjustments is required is the linagliptin in the CKD. If you want to use the sitagliptin, you have to reduce the dose. If you want to use the saxagliptin, better not to use the saxagliptin because it is associated with the failure of heart failure, which is very common in the CKD population. Vildagliptin, you want to use the vildagliptin, continue, but at a reduced dose. And then the insulins, they're very good. But the only thing here in the CKD population is hypoglycemia. So CKD population, they get the hypoglycemia very often. So when you are using the insulin, so better to reduce the doses of the insulin when compared to the non-diabetic, non-DKD population or CKD population. Suppose one fellow is one Ramarao and Krishna Rao is there. Krishna Ramarav's creatinine level is 4. Krishna Rao's creatinine level is the normal. So for the same both body weight or both blood sugars high elevated, if you want to use 20 units for the both people, this Ramarao will die very fast. Because 20 units in the presence of the CKD is hypoglycemic. Whereas 20 units in the presence of hyperglycemia, the second fellow is good. No hypoglycemia. So you have to respect the CKD function or kidney function as far as hypoglycemia is concerned. I told you that hypoglycemia is much more dangerous than the hyperglycemia. And hypoglycemia will kill the patient, provided if it is neuroglucopenic hypoglycemia or very severe hypoglycemia. So don't allow our DKD population to have the hypoglycemia by introducing the insulin at higher dosages. Always start low and go slow. Sulfonylureas. So don't use sulfonylureas in the CKD population because all sulfonylureas will cause hypoglycemia. If you want to use the sulfonylurea, only one sulfonylurea is good. That is the glipizide because shortest acting sulfonylurea. So in our state, Uddanam is there, Srikakulam district. So a lot of the people are there, diabetic and CKD population. So even if you want to use the insulin, so they may not use because all the rural background. So they may not use the insulin as you suggested that. So then if you want to use the sulfonylurea, I think the glipizide is the best drug to use in those individuals because of the shortest acting sulfonylurea. You don't use the glibenclamide in the CKD population because it's the longest acting sulfonylurea. And if the person gets the hypoglycemia, it will last for about 2 days or 3 days or 4 days. So that is very, very dangerous. So don't use the glibenclamide or your Dionyl in the CKD population. Use the glipizide. TZD. What is TZD? Thiazolidinediones, your pioglitazone. So don't use pioglitazone in the CKD population because this TZD will cause pedal edema, will increase the body fluid volume. So already in the CKD population, they are more prone to have the heart failures. So again, the heart failure risk will be increased in the presence of the TZD. Otherwise, no, you can use the TZD till the creatinine level is of 3 or 3.5. Alpha glucosidase inhibitors. So your Oglibose or your Acarbose, you can use them in the CKD, but unfortunately, most of the CKD individuals will have nausea and vomiting or loss of appetite or abdominal discomfort. So again, the alpha glucosidase inhibitors, they act locally on the intestines. So they cause abdominal cramp, they cause nausea, they cause vomiting, etc. So for that symptomatic, suppose the patient is a symptomatic, gastrointestinal symptomatic in CKD population, don't use the alpha glucosidase inhibitor. Okay. So the treatment long-term intensive glycemic control is established in preventing the DKD, particularly in the early stages of the disease. Targets for glycemia should be tailored to the individual's patient's age, comorbidities, life expectancy as recommended by the ADA. So summary of the SGLT inhibitors on the renal disease. So you have the EMPA, you have the canagliflozin, and then you have the dapagliflozin. So there are 3 SGLT inhibitors are available in the market. So nowadays we are not using the canagliflozin. We are using either the empagliflozin or the dapagliflozin. So these are the different trials names. So you are very familiar with the DAPA-HF. So the dapagliflozin heart failure and the DAPA-CKD. So dapagliflozin CKD population. So management of the hypertension, CKD in the diabetes. Initiation of the pharmacological treatment for the hypertension is recommended at the specific systolic and the diastolic blood pressure levels, and the different medications regimens are suggested based on the patient's characteristics. Renin-angiotensin system blocks with ACE inhibitors or ARBs is evidence to reduce the DKD progression in patients with macroalbuminuria although combination therapy is associated with increased risk and no clinical benefit. So we don't combine the ACE inhibitors on ARBs. Preferably, either you have to use the ACE inhibitors or ARBs. Don't combine the ACE and ARBs. But ACE and ARBs can be combined in the hands of a senior nephrologist. So very few people, senior nephrologists, they combine the both ACE inhibitors or ARBs. Even though they get the hyperkalemia, so they already have the dialysis on their hand. So they use these dialysis machines in them to reduce these things. But without the dialysis, as a normal physicians or our subspecialties, so better not to combine the ACE inhibitors or ARBs. Use either ACE or the ARB. ACE means your ramipril. ARB means your telmisartan or olmesartan, etc. Sartans here, prils there. So the management of the hypertension, effect of the intensive blood pressure control on the cardiovascular outcomes in the diabetes. So this study intensive BP control versus the standard BP control in a diabetic patients. Intensive treatment group showed a 25% reduction in the primary cardiovascular outcomes and 27% reduction in the all-cause mortality compared to the standard treatment group. So you all agree with me that good control of the blood pressure is always needed in our diabetic individuals. That is intensive. Intensive means keep the blood pressure below the 130. Systolic. Diastolic around 80. Standard means less than the 140 and less than the 90. So always better at systolic 130 and the diastolic 80 when compared to the 140 and the 90. So treatment of the CKD in the diabetes, see the bottom line. You have the exercise, nutrition, cessation of the smoking, good glycemic control, BP control, lipid control. These are all patients. So all patients require all these things. Okay. And then most patients, they require SGLT inhibitors, either dapagliflozin or empagliflozin, and RAS blockade, that is our ACE inhibitors or ARBs. And then some patients, they may require the antiplatelet therapies, provided the patient is at high risk of getting the ischemic heart disease. So am I clear? So the patients with the diabetes and CKD should be treated with a comprehensive strategy to reduce the risk for the kidney disease progression and the cardiovascular diseases. So what are the novel therapies? Despite the current approaches to manage the diabetes and hypertension, use of ACE inhibitors and ARBs, there is still a large residual risk in the DKD. So even then, even though we use all these things, still there is a big residual risk in the DKD. So the novel agents targeting the mechanisms such as the glomerular hyperfiltration, inflammation, fibrosis is a major focus for the development of the new treatments. So here your finerenone. Okay. So it's a novel, a non-steroidal, a selective mineralocorticoid receptor antagonist. So overactivation of the mineralocorticoid receptors, finerenone, is a non-steroidal and the bulky. Okay. Unique structure results in the selective and the potent interaction with the MR and the regulation of the gene expression. MR means mineralocorticoid receptor. So exhibits anti-fibrotic and anti-inflammatory effects. Okay. It's approved in India with the same indication. Indicated in the adult patients with the CKD associated with the type 2 diabetes to reduce the risk of sustained GFR decline, end-stage kidney disease, cardiovascular health, death, non-fatal myocardial infarctions, and hospitalization for the heart failure. So these are all indications to use your finerenone. Very high risk individuals, those people who can afford, who can use the finerenone in those individuals. It is highly selective for the mineralocorticoid receptors. No off-target sexual side effects associated with the finerenone treatment. It had a modest effect on the systolic blood pressure. Had no effect on the HbA1c. So it is a glucose friendly. On the other hand, it reduces the blood pressure also. So ADA and KDIGO consensus recommendations for pharmacological management of CKD. So you can use the metformin, you can use the SGLT inhibitors, you can use the GLP-1 receptor agonists, you can use the statins, you have the RAS inhibitors, and finally finerenone also. So you are all using all these drugs in the CKD population. So metformin according to your GFR, according to your creatinine levels. SGLT inhibitors again according to your creatinine levels. GLP-1 receptor agonists according to the patient's pocket. Statins for all individuals. RAS inhibitors all individuals, but you respect the potassium levels. Whenever you use the RAS inhibitors or ARBs, potassium and creatinine levels. Once the creatinine is beyond 4 and 4.5, stop using it. Again, the potassium level is more than the 5.5 or the 6, stop using these drugs or reduce the doses of these drugs. And finerenone, yes, again you have to respect the creatinine level and also your potassium levels in the finerenone also. So thank you very much for your patient hearing.